Hello, everybody. Today we're going to begin talking about central nervous system, and we're going to begin by talking about central nervous system stimulants that are going to increase the effects of the central nervous system. And certainly we're going to talk about more details, how exactly it will do this on the central nervous system. And we will talk about conditions such as ADHD. We're also going to talk about analgesics, and these are going to be used for pain relief. We will talk about opioids, and then we are also going to talk about migraine headaches. So let's get started. Why exactly would we see central nervous system stimulants being used? Well, we do have some different conditions where we will see these being used. We use these for attention deficit hyperactivity disorder, otherwise known as ADHD. Narcolepsy is a condition that increases somnolence with patients where they would be falling asleep at random times. And so we could use the stimulants in order to help keep them awake. And then obesity is another reason why we see these being used. And of course, think about it's a stimulant, it's speeding things up. And so if it is speeding up things like metabolism, digestion, that will help somebody to lose weight. I suggest that you go to your Nursing Central app and look up caffeine in Nursing Central. If you want to know exactly what a stimulant is, Nursing Central gives you a good idea. If you look up in the Tabor's dictionary, it talks about stimulating the central nervous system and how we will see improvements in respiratory function. We will see an increase in the secretion of gastric acid. We will see diuresis, increase in metabolism, like I just mentioned, a decrease in total sleep time, and then possibly an increase in blood glucose level. Another area in Nursing Central that you could look up is if you would go to Nursing Central and research, you can just type in depression or depressive. And if you just go to depressants, that might be easier. And if you go to diseases and disorders, then you will see an area to click on withdrawal from signs and symptoms. Or if you would just like to look up psychoactive substances in Nursing Central, you certainly could do that also. But of course, we are in the diseases and disorders. And if you go down to physical exam, you will see a table that has signs and symptoms of drug use and withdrawal. And the table's really nice because it separates out and you'll see stimulants in there. It talks about amphetamines and cocaine. Of course, it talks in there about what an overdose would look like and then what withdrawal would look like. And so certainly you do have a good resource in Nursing Central to learn a little bit more, whether it's about the conditions or about the specific drugs that we are going to talk about. When it comes to stimulants, we do have some examples of different types of drug categories that would fall under the stimulants. We have amphetamines, and of course, included in this, we do see some illegal amphetamines, such as methamphetamines. And just think about how it's a central nervous system stimulant. It's going to speed things up, it's going to also produce wakefulness. Methylphenidate, we're going to talk more about that because we will see that being used for attention deficit hyperactivity disorder, so ADHD. We also see falling under the stimulants as methylxanthines, which would include caffeine, why in the world would we see caffeine and why are we talking about it in pharmacology? Well, caffeine is technically a drug. Of course, there's many substances that are over-the-counter products, including food products such as coffee, certain teas will have caffeine. And, why are we thinking about it? Well, certainly caffeine can be used to treat medical conditions. It can be used to treat respiratory distress, and the medications would work by stimulating respirations. We also can see the use of caffeine for headaches. It is actually included in a medication called Furoset, which is a combination medication that includes a barbiturate. It also includes acetaminophen, otherwise known as Tylenol, and then caffeine is also used in there. And so why would we use it for a headache? Well, remember, it's a drug, and since it's a drug that is a central nervous system stimulant, a person could go through withdrawal if their body is so used to having caffeine maybe on a daily basis and maybe being used several times throughout the day. A person can certainly build up a tolerance and a dependency to the medication. And the thought process is that going through the withdrawal from the caffeine can lead to the headache. And so if we can give them a medication that has caffeine, that can help the headache go away, especially if it was caused from withdrawing from the caffeine. If you haven't thought much about caffeine being a drug, yes, it certainly is a drug. And so I encourage you to think about this the next time you are ingesting maybe a lot of cups of coffee throughout the day, or maybe you've been using energy drinks. They're not necessarily the best products since of course, the caffeine, you could build up that dependency to that caffeine. On this slide, we can see the therapeutic effects of a central nervous system stimulant. And we can see right there, it talks about how it will help a person to stay awake by increasing wakefulness. It will also increase alertness, where somebody will be able to focus better. And then, of course, um, if somebody is having trouble with a lot of fatigue and they're just feeling tired. And now we can see it being used to reduce fatigue. Hence, a lot of times why people are ingesting caffeine is because they are feeling tired. And so they're ingesting the caffeine so they can feel more awake. We also see that the stimulants can elevate mood, help somebody to feel better. It can also help somebody to be more self-confident and have more initiative, where now they could get more work done. It can stimulate respirations, like we were already talking about on the previous slide. It can suppress appetite, and certainly that would be useful if our patient is struggling with obesity and we're trying to use medications to help them lose weight. We can also use these to suppress the perception of pain. And so when you think about the reasons why we use these medications, you can see right there those therapeutic effects that we can get from using central nervous system stimulants. We've already mentioned that caffeine, which is a stimulant, can lead to tolerance and dependence. And any of these central nervous system stimulants can do the same thing. So we could see that tolerance developing, especially if the person is using the stimulants on a regular time frame, such as daily or multiple times per day. And the tolerance would be over time, they would need to have an increased amount of the drug in order to get the same effect. Dependence, we can see that where the body is becoming dependent on the medication, where now if they don't ingest the medication, their body would go through withdrawal symptoms. And I did include what some of those withdrawal symptoms might look like. And so with the stimulants, we also see this high potential for abuse. If you've ever done any research on methamphetamine, which is an illegal substance, we can see people that become very dependent on methamphetamines. It's very hard to get off of methamphetamines. And, it makes sense when we think about the type of drugs and, of course, the abuse that is happening with the drugs. Talk a little bit about attention deficit hyperactivity disorder. When it comes to the cause of ADHD, we don't have a whole lot of information regarding the pathophysiology. They do have a theory. They do believe that we have this dysregulation of neurotransmitters when ADHD is happening. And so the neurotransmitters of norepinephrine, dopamine, and serotonin are not up to the levels where they should be. I like this picture because it shows the process of ADHD, and you can see the risk factors are going to be listed across the top. We do know that genetics plays a major factor in the risk of developing ADHD. And then, like we talked about on the previous slide, right there in the middle, we see the same information. And now it's talking about the dysfunction of dopaminergic activity in the prefrontal cortex, and then dysfunction of the adrenergic activity. And of course, remember that would then be the sympathetic nervous system. And so can you see why we were talking about the autonomic nervous system so much in past classes? Is because now we're going to relate it to a condition. And of course, now you can see again there in the middle of the picture, it talks about altering the neuron activity in the cortical regions involved in attention and then also impulse control and the stimulus of integration abilities. And now, what would that look like? Well, ADHD in childhood, we can see the hyperactivity listed there on the left-hand side of the picture, where now we have a child who is talking constantly. And, a child who has developed this, typically it's around age 7 when we are seeing this. And of course, that would be a school age child. And just imagine the child being in the classroom at school, and now they're talking excessively. Will the teacher be able to actually teach the children if you have a child that is disruptive by talking? Other things we see with the hyperactivity would be fidgeting, restlessness, where now maybe they won't sit in their seats. And if they're at school, they're not sitting at their desk like they're supposed to be. We can also see a poor attention span, where, of course, thinking of school age child, are they going to be able to concentrate and focus on getting their schoolwork done or getting their homework done? They might not be able to do that. And of course, it's not that they're being defiant, it's because of the condition that's leading them to these signs and symptoms where, it's not going to allow them to be productive in their school day. They also might not be able to stay focused on one task at a time. And so if we're trying to get them to concentrate on completing one assignment, they might have difficulty doing that. And then, of course, because of this hyperactivity, it could lead to behavior issues where now the parent or parents might be getting phone calls from the teachers saying, hey, look, we're trying to teach this child, but we're really having difficulty because the child's just not listening. We could also see sleep disturbances with this child. And then impulsivity. And you can see listed there on the slide, it goes into a little bit more detail about what impulsivity is. This could be where they're blurting out answers before maybe it's the teacher asking a question and they haven't had a chance to ask the question completely, and now the child is blurting things out. They might have difficulty awaiting their turn, and certainly now we could see frequent interruptions. And of course, this could be difficult in a classroom setting. You can see on the right-hand side, it talks about inattentiveness, just being easily distracted, not able to focus on one thing like we've already talked about. ADHD can occur in adulthood, but it does look a little bit different. And so the clinical picture of the patient would look different. They wouldn't have all the same signs and symptoms as a child would have. And so as an adult, it could just be difficulty with attention. It may be that at their job, they're underperforming. And again, it's not that they're purposefully trying to do this. It's just that their condition is preventing them from performing at that optimal level at work. We could also see similar signs and symptoms to mood disorders such as depression and anxiety with ADHD in adulthood, which could lead to misdiagnosis. And now we might not be getting the right diagnosis for the adult patient. And of course, that could lead to mistreatment also, including mismanagement of medications. Here we see a little bit more about who is affected by ADHD. Mainly, it's going to be children, and typically we're seeing the signs and symptoms before age 7. And so a lot of times we are getting that diagnosis of ADHD while they are a child. But like we talked about on the previous slide, it might have gotten missed during childhood. And so the diagnosis, it might not be identified until adulthood. When we look at who exactly this is going to affect, it doesn't matter as far as ethnicity or race or socioeconomic class. It does affect multiple areas or multiple realms when we look at races, ethnicity, and socioeconomic class. We do see gender differences. And so we do know based off of statistics that it does affect boys more commonly than girls. Specific medications can we use to treat ADHD? Well, like we've already mentioned, central nervous system stimulants, they are going to be the drug of choice. Why? Well, we have to look at how exactly the medications work. The medications are going to work by releasing norepinephrine and dopamine within the brain and working on the sympathetic nervous system area of the brain. And that is going to help to increase the person's alertness and focus. And we think of our school age child, now they will be able to focus on their schoolwork. They'll be able to sit in their chair. They'll be able to complete the assignments like they are supposed to be doing. Some of the medications not only increase the release of norepinephrine and dopamine, but they can also block the reuptake of norepinephrine and dopamine. What does that mean? Well, reuptake would be taking the neurotransmitter and pulling it back up so we could use it again in our bodies. And so it would be pulled back up, and you can see it on the picture there, just pulling the neurotransmitter back up, and so blocking that from happening. And essentially what is it doing? It's going to increase the amount of norepinephrine and dopamine in order to help the person to focus better and be able to complete daily tasks that they are supposed to be completing. Because central nervous system stimulants work on the brain and the spinal cord, we certainly can see several side effects that can come down from us administering a central nervous system stimulant. And so pay attention to these. Remember, the stimulant's going to really be speeding things up. And so now we can see the vital signs being affected, such as the heart rate speeding up. It could also elevate respirations. It could also increase blood pressure. And so pay attention to all of the vital signs when we are administering central nervous system stimulants. Another part of what's happening in the body, metabolism gets sped up when we are stimulating the central nervous system, and that can lead to weight loss. It can also suppress the person's appetite, leading to anorexia. Because it is affecting the brain, we can see signs and symptoms that the brain is being affected, such as dizziness. It could also lead to agitation. And, you might say, well, the therapeutic effect said that it's going to help the person to focus, but now it could do additional things where now, a lot of times as a child, we are treating with the central nervous system stimulant. And so now they could be getting agitated. And remember, it's just going back to the medications themselves causing these side effects. Let's talk a little bit about an example of a CNS stimulant for ADHD. We have methylphenidate, otherwise known as Ritalin. We also have different forms of methylphenidate, such as Concerta and Daytrana, and you can see that they come in not only PO form or oral form, but we also have a sustained release. That's the Concerta. We have the Daytrana. That would be a transdermal patch that would go on the skin. And so we do have a lot of different options for treating ADHD with a CNS stimulant. Most of the children that are using a stimulant, they are going to be on the methylphenidate Ritalin. When it comes to thinking about why are they using it, well, go back to the therapeutic effects of giving a central nervous system stimulant. Remember, it can increase wakefulness and alertness. Alertness would be helpful for a child to be able to focus on their schoolwork. It can also help reduce fatigue, make them happy, so elevating that mood. It can also help with self-confidence, initiative, get the work done. That's very helpful for a school age child. And so, just pay attention to the big picture of things when we are administering the medications. You have to think about what's the therapeutic effect of the medication, and then how exactly is the drug working in the body. Most of the time it's working somewhere in the pathophysiology. And then, of course, we have to think about side effects, because it's not just going to bind to one specific receptor. So we're going to end up seeing multiple side effects that can go along with drugs. As nurses, we need to think about what would be interventions that will go along with giving a central nervous system stimulant. And of course, most of the time it's going to be the parent who is giving the medication to the child. And so certainly we would want to go over what exactly the side effects that the child might start having from taking a central nervous system stimulant. And so again, we have that on a previous slide. So as the nurse, certainly we would want to educate them to monitor for the central nervous system side and adverse effects. We've already talked about how the vital signs could be sped up and increased. And, we especially want to think about a child's blood pressure and make sure that the blood pressure is staying within normal limits. We don't usually see the other vital signs such as respirations or pulse or temperature. We don't see those elevating outside the normal limits, but certainly the blood pressure could elevate too much where now it would be considered hypertensive. When it comes to these stimulants, remember they do have a high potential for dependence and abuse. And so the prescriber might actually prescribe where the child has a med-free period of time in order to reduce this dependence and tolerance. And so if it's a school-age child, they might prescribe the medication to just be taken on those school days, which would be Monday through Friday for most of the school-age children. And then on the weekend, they would get a break from taking their medication. We would not want the patient to be taking over-the-counter medications. That's what OTC stands for. And so just talking to the parent, making sure they understand that the child really shouldn't be taking any other over-the-counter medications because there could be drug-to-drug interactions with their medication. One thing that's very important is to make sure that the parents understand that the child should be taking their last dose of the medication at least 6 hours before bedtime. Why does this matter? Well, because remember, it's a central nervous system stimulant and it's promoting wakefulness and alertness. And now, what will happen if they take it too close to bedtime? Well, guess what? Now the medication will keep them awake all night, and now they won't be able to sleep. And so now they would be experiencing insomnia, and now we would be causing problems for them. And so, talk to them about when they need to take the medication. Typically, the medication is going to be given before breakfast and before lunch. If it's a patch, it might just be a once a day where we need to remove the patch then at least 6 hours before bedtime. And so just pay attention to that. We don't want to cause them more problems just by if they are taking the medication at the inappropriate time. We've talked about how stimulants can suppress the appetite, and so it could lead to the child not being hungry. It could lead to weight loss. Well, is this okay for a child? Think about the age of these patients. What should a child be doing during childhood? Well, remember, they're supposed to be gaining weight, they're supposed to be growing taller. We have development that we are expecting them to achieve in childhood. And of course, they're advancing to then eventually get to that adult weight and height that they will be. And so certainly we need to periodically monitor the child, monitor their height, their weight. And so they might have to go to see a provider more frequently than other children just because we need to monitor that height and weight a little bit more closely, just making sure that they aren't losing weight when they should be gaining weight. We don't want to have any development delays happening. And then, of course, we really should talk to them about how the therapeutic effect, it might take several weeks. And so just educate the parents that they need to just continue to give the medication as prescribed and make sure they understand. It might take a little while until we see the good therapeutic effect from the medication. We talked about how the stimulants, they can be used for narcolepsy. There's newer research coming out that with our cancer patients who are struggling with fatigue and that chronic fatigue just because of the cancer, we are seeing those doctors prescribing, or those providers prescribing, the central nervous system stimulants such as Ritalin to be used for chronic fatigue. And so, not necessarily used for narcolepsy, but, it's going to work pretty much the same way as why we would use it for narcolepsy. So just pay attention. You might see some additional reasons why the patient is prescribed a central nervous system stimulant. Just going back to, we talked about the dependence and tolerance with central nervous system stimulants. Just an FYI, there is this high abuse potential. We want the patient to be taking the medication as prescribed. We know there's a high abuse potential. Right now, it costs about $1 up to $50 per pill on the street. We would not want our patients to be selling their prescription drugs to be making a profit off of these. And so pay attention to that. These are those stimulants. If somebody is abusing central nervous system depressants, a lot of times they want a stimulant in order to help keep them awake throughout the day. And we don't want to be promoting the abuse. So just pay attention to that also. The provider is worried about dependence and tolerance and abuse of the central nervous system stimulants, we do have other options for ADHD or for chronic fatigue or for narcolepsy. And so we do have atomoxetine, which is not a central nervous system stimulant. It's working differently in the body. It is working on norepinephrine, though, and it is considered a norepinephrine reuptake inhibitor, and so it's going to allow more norepinephrine to be available for the body to use. It's very easy to administer this medication also because it's only once a day, and it's a PO medication. There are some complications that can go along with this medication that we certainly need to be aware of and pay attention to. This medication, it does carry what's called a black box warning. Why? Well, it can actually increase the risk of suicidal ideation. And why does that matter? Well, in our country, we are seeing an increase of suicide rate. And so now this medication can lead to suicidal ideations. And of course, if it's a child that we are prescribing this medication to, we do have to worry about that. Just because they're a child, it doesn't mean they won't follow through with suicide. And so certainly we need to make sure we understand that. And of course, the patient needs to understand that increased risk, and the parents need to understand if it's a child. And then, they need to know when to reach out for help if they are having these thoughts in their head, thoughts of harming themselves. We do see some additional side effects. It can also affect vital signs. It can also increase blood pressure. It can increase heart rate. For most children, this would be okay, but what if we have a child that has cardiovascular disease? Well, that could be a problem for that child. So certainly we would use cautiously with that child. Another side effect that could occur is appetite suppression, anorexia, where they're not hungry. That could lead to weight loss. So again, think about those nursing interventions. We would want to monitor vital signs. We would want to educate about the suicide ideations. We would want to teach them when to reach out for help if they are having suicidal ideations, and then monitor their height, monitor their weight, making sure that if it's a child, they are meeting those developmental milestones. If the central nervous system stimulants haven't worked for the person that's experiencing ADHD, and maybe they've tried the atomoxetine already, and maybe that didn't work so well, guess what? We still have additional options to treat ADHD. We have the guanfacine and the clonidine, which are alpha 2 adrenergic agonists. So again, remember, just think about the alpha 2 adrenergic agonist. How is it working? Well, it's working on the alpha 2 receptor. What does alpha 2 do? And it's an agonist, so it's going to be doing the same thing as what stimulating alpha 2 would do. We don't know quite how these meds work in the body, but we are seeing positive results. And so again, just more options. These meds both were originally approved for hypertension, but we are seeing them used for ADHD. We do have side effects with these. If we had a person that is having complications with insomnia, maybe a side effect from the other medications. Now this medication, it actually could lead to somnolence. That might be a problem, especially if it's a child who's trying to complete their schoolwork. Now they might be falling asleep at their desk. Maybe it's an adult person using this medication, and now they're falling asleep at work. Certainly that could interfere with their quality of life. We could see weight gain with this medication or these medications. And so maybe the patient was already on the central nervous system stimulant and they were losing too much weight. And so now the provider might switch them to this to try to get them to gain the weight back, so they are reaching those development milestones. We can also see decreased blood pressure. So again, maybe the other medications, they were having complications with their vital signs. And so now this medication might bring their vital signs back to normal. All right, now let's move on and start talking about analgesics that are going to be used to manage pain. This is not going to be the only time we talk about pain medications. Again, in week 9, we will talk about pain management. But certainly, as nurses, you are going to be taking care of patients that are experiencing pain. And of course, we have to remember, what type of pain are they having? There is a difference between acute pain and chronic pain. Acute pain is going to be what you deal with a lot of times. Why? Well, it could be because your patient was admitted to the hospital or admitted to the outpatient surgical center because we are conducting a surgery on them. And think about that. We're cutting into their skin, we're going into their body to do whatever we're doing in this surgery. And certainly that could be a painful event. It could be that your patient injured themselves and now they are having pain related to that injury. It could be a trauma of some sort. Maybe it was a motor vehicle accident, or maybe they fell down the stairs and now they broke their leg. Or it could be that they have infection going on, and now because of the infection, that has led to the pain. But we can see that there is an identifiable cause for the pain. And because of that, we do see that the acute pain will resolve within a very predictable and specific time frame. Chronic pain is going to be pain that has lasted longer than 6 months of time. And we are seeing differences as far as why the patient would be experiencing chronic pain. What they believe is happening is that there are physiological changes within the central nervous system that is leading to this pain that is lasting for this extended period of time. A lot of times what is happening is the chronic pain is being caused by us undertreating or not treating the acute pain. And so it might be that the patient themselves, they don't want to take any pain medication and they're just trying to, suffer through the pain. Maybe they think that it will just go away on its own, and they don't realize that if it's undertreated acute pain or untreated acute pain, it could lead to chronic pain. And, certainly we don't want that to happen for our patients. We do have a lot of Americans that suffer from chronic pain every day. It is a very common occurrence. And so pay attention to that. You're probably going to take care of patients that are going through and suffering with this chronic pain, and it might be very difficult to treat them for their chronic pain. We do know some other information also, some statistics. I never expect you to remember statistics, but roughly about 20 to 29% of patients who are prescribed opioids for chronic pain, they will misuse them. So pay attention to that also. To talk a little bit about a class of drugs called opioids, which are analgesics that are used to treat pain. Opioids are also known as narcotics. Opioids is just a general term, and it is going to be a natural or a synthetic substance that is going to work very similar to morphine within the body. When it comes to opioids, they are going to bind to the opioid receptors. We do have three main classes of opioid receptors called the mu, the kappa, the delta. The pain medications that we administer that are opioids, primarily they are going to exert their effect on the mu and kappa receptors. And you can see that I have a picture on my slide on this slide. You guys have that same picture. It's on the next slide if you wanted to look at that picture. But you can see specifically the receptors in the body and what specific effect that if we trigger those receptors to turn on, what are they going to do? And of course, primarily, what do we want to do with opioids? Well, we want to take away the pain. And you can see right there the mu receptors. We have a mu1 and mu2, and you can see what exactly would happen. And of course, you might not necessarily see the therapeutic effects from these receptors that are being turned on, but certainly some of those side effects that we will see are as a result of turning on these receptor sites. You certainly can see the kappa receptor site will lead to spinal analgesia, which is helping to relieve that pain. When it comes to these medications, I'll refer you back to Nursing Central. Remember, previously we looked up in Nursing Central the psychoactive substances, and we were looking at under the physical examination portion, there is a chart that goes over and talks about narcotics. It also talks about depressants. Remember, opioids are central nervous system depressants. We talked previously in this lecture about central nervous system stimulants. And so kind of thinking about what is it doing in the body? Well, the depressants are going to be working, again, it's central nervous system, so working on the brain, the spinal cord. And of course, we are seeing now things slowing down. And so the medication will cause the respirations to slow down. It will cause blood pressure to slow down. It will cause the heart rate to slow down. Doesn't mean it's going to cause them to slow down too much, where now their vital signs are outside of the normal range, but certainly it could lead to that, especially when we look at the mu2 receptor. You can see it can lead to respiratory depression, and that could be significant where now they're breathing slow so much where now it could lead to them stopping breathing, and that could lead to death. So very serious things that we need to consider when we are administering opioids. All of the opioids have very similar side effects or adverse effects, and some are going to be very serious adverse effects that could lead to death, while other ones could disrupt their quality of life. And so pay attention to these also. As the nurse, you're going to be assessing for these side effects. Respiratory depression is a very serious side effect, like we've already talked about previously. It could lead to the patient to stop breathing, and now it could lead to death. So pay attention to that. If you are giving an opioid, you need to go back and you need to assess your patient's vital signs. Make sure that their breathing has not slowed down too much. Constipation is another common complication that can occur. And of course, this could be very uncomfortable for our patient. We do need our patients to be able to eliminate. And so now, if the medication is interfering with their ability to eliminate, that certainly can lead to elimination complications. We can see blood pressure lowering, especially if the patient moves about too quickly. It could lead to orthostatic hypotension. So again, teach your patient to move from laying to sitting or sitting to standing. They should move slower, especially if they start experiencing lightheadedness, dizziness. That could go along with orthostatic hypotension. Urinary retention, we could have a patient where now they are having difficulty eliminating their urine. And so, just talk to them about making sure that they are getting enough fluids, making sure that they are allowing enough time to empty their bladder when they are going to the bathroom. It could lead to cough suppression, which is a good thing in some cases, because sometimes we use opioids if somebody has a bad cold and they are coughing and the cough is just tremendous where it's disruptive to their life, very irritating to their life. Now we could actually use the opioids in order to suppress the cough. But what if we have a patient who maybe they're taking a drink, and as they are trying to swallow, it goes down the wrong tube, and now instead of being able to cough to clear their airways, now the medication is preventing them from coughing, and that could lead to aspiration, that could lead to pneumonia, that could be a very serious thing, and it could lead to death. So pay attention to that. Nausea and vomiting is another very common side effect that we see with the opioids. And, you might have a patient in a lot of pain, and now the medication's leading to nausea, vomiting, and that could cause them more pain and could be very uncomfortable for them. So pay attention to that. If they are experiencing nausea and vomiting and they're having a lot of pain, we wouldn't want them to stop taking their opioids, but instead we might include an antiemetic, which would treat the nausea and vomiting that is being caused by the opioid pain medication. Sedation is another common side effect from the opioids, where now they might take the medication and now they're falling asleep. And this might be a good thing. If the patient just had surgery, we would want them to be resting so they can heal from surgery. But, what if they were having chronic pain and they were using opioids over a prolonged period of time? Now the medication might be disruptive to their life, where maybe now they're not able to go to work because they are just so tired throughout the day. The medication also could lead to additional central nervous system side effects such as confusion, hallucinations. Where would those side effects be coming from? Well, it would be from in the brain. And remember, these medications are working on the central nervous system, which would include the brain. And so, again, we need to be monitoring our patients' level of consciousness. And if they are having confusion or hallucinations, that could be very serious and disruptive to their quality of life also. So pay attention to those adverse effects. Opioids could also lead to meiosis, which would be pinpoint pupils where the pupils are very constricted. So pay attention to that. Going back to the respiratory depression, why would this happen? Well, the medication actually causes carbon dioxide to increase in the body, which then causes dilated cerebral vessels, which then leads to increased intracranial pressure. So not only can the medication cause respiratory depression, but now we could see increased intracranial pressure because of the respiratory depression. So again, make sure you're assessing your patient for these side effects. When it comes to opioids, we do need to think about dependency because certainly they could become dependent on opioids. A lot of times, if somebody is using illegal or illicit drugs, opioids does tend to fall into that type of use also. And so pay attention to that. When it comes to dependence, when would it occur from opioids? Well, it would most likely occur if they were taking high doses and they were taking it for a prolonged period of time. If your patient has had surgery and it's an acute pain situation, they are not likely to develop dependence on that. But certainly, nurses might even think that the patient could develop dependence after a surgery. And so we do have evidence showing us that most nurses do tend to under-medicate if their patient is experiencing pain because they do fear addiction. They also fear causing harm to their patient, and they are worried that the opioid could lead to respiratory depression, and that might lead to them under-medicating their patients. We do have evidence, it does show us that the dependence does rarely occur if opioids are given to treat acute pain. And so certainly we need to make sure the patients have a good understanding of that, and also that the healthcare providers have a good understanding of that. Like we've mentioned earlier, tolerance is another possibility with the use of opioids, and this would be where the patient would have to take larger doses or more frequent doses in order to produce the same response as previous use. The tolerance itself would develop to not only the analgesia, so for the pain relief, but it also can develop for the euphoria that could be experienced and also the sedation. One positive thing when it comes to tolerance is we do see tolerance also developing for respiratory depression. Why do I say this is a positive thing? Well, if a patient is dependent on the drug and they are using higher doses or they're using more frequent doses, it doesn't mean they are more likely to die from it, from respiratory depression, because they are developing this tolerance. And so it's not going to increase that risk for respiratory depression. When it comes to using opioids in the clinical setting, they do work very well to help provide that pain relief, especially from acute pain situations such as injury, trauma, or surgery. And so, when it comes to then as the nurse and we're administering the medication, we have to pay attention that we are in the midst of an opioid epidemic. And certainly we don't want to cause our patients to start abusing the opioids. So it's really this fine balance of making sure we're providing enough opioids in order to give that therapeutic effect of pain relief. And at the same time, we need to minimize abuse. We also need to, make sure that we are minimizing the fears regarding that physical dependence, the overall addiction. And so, if we are sending a patient home with a prescription for opioids, just it's a good idea to have a conversation, make sure they understand they really need to take the medication as prescribed, and make sure they are not taking more doses than what's prescribed, or, taking it more frequent than what is prescribed. So that's really the key. Take it as prescribed. And, even if they are on opioids, uh, before they leave the hospital, we really should be trying to switch them to non-opioid pain medications such as ibuprofen or acetaminophen, because certainly we know those drugs are going to be safer and not have that risk for the dependence or the tolerance. There are some nursing interventions that would relate to opioid administration. As the nurse, if your patient is experiencing pain, we really should be assessing their pain. And it wouldn't just be an assessment where we're only asking how bad the pain is. We want to make sure we're doing a very comprehensive pain assessment. And an example I put on there is the OPQRSTU assessment that could be performed. Make sure, if you don't know what that is, you certainly could look that up. Those of you in fundamentals, you will be learning about that, and certainly you could look that up in your fundamentals textbook. If we are thinking about administering pain medication, we need to have the comprehensive assessment done before we administer the medication. And then how are we supposed to know whether or not the medication is working? Well, we would have to go reassess them to evaluate that effectiveness. And so we'll have to do multiple pain assessments. So before administration, and then if it's a PO medication that we gave, about an hour after administering that medication, we could go back just to make sure that it did work for the pain and their pain is at least being reduced. It's not realistic to think that it would absolutely take their pain away, but we would certainly expect it to be getting better after using the pain medication. Don't forget to assess vital signs. We know that the medication, the opioids, can lead to respiratory depression, can also lead to hypotension. So certainly our vital signs are going to be important assessments. And it should not just be only one time a nursing shift doing these assessments. If they are on opioids, we need to be performing these assessments more frequently. Since we do know that opioids can lead to constipation, well, certainly let's assess the bowel function. Are they able to pass their feces? Are they having a lot of pain with that? We certainly could implement additional measures to prevent that constipation, such as increasing fluids or increasing their fiber in their diet. We could also get them up and ambulate, make sure that they are able to eliminate their bowels and have it not affect their quality of life. When it comes to pain, it doesn't mean that we have to provide pain medications in order to treat their pain. There are non-pharmacological pain relief measures that we could also implement at the same time we are administering opioids, and that could include position changes. It could include using heat or using ice to the location of the pain. It could include distractive measures where maybe listening to music or maybe reading a book, something to get their mind off of that pain. if by chance we are going to perform a procedure that might cause our patient pain, we could be proactive and talk to them about administering the medication prior to that painful activity in order to decrease that possibility of pain. If our patient had surgery or if they were injured, maybe it was a motor vehicle accident, think of little things that could be painful activities. It could just be getting them up and ambulating them for the first time. It could just be helping them get washed up. That could cause them pain. So if we can be proactive and pre-medicate them, that certainly could help decrease that pain from us doing a specific activity with them. Other things to think about is, things like auscultating their breath sounds. Remember that opioids can suppress the cough reflex. And so certainly let's make sure they haven't auscultated or aspirated and any fluids into their lungs. And so certainly we need to listen to those lung sounds. We know that the medication can affect the central nervous system, including the brain. And so certainly we should monitor the patient's level of consciousness. That's what LOC stands for. Other things that we should think about is our patient's safety, since we do know that opioids can affect the central nervous system and the brain. Now it could affect their cognition, and their safety could be at risk. And even little things like getting up out of bed, they might be so drowsy, they might be dizzy, they might be nauseous from the medications. And so even ambulating the patient, we might tell them that they need to call us ahead of time and we'll come in and help them ambulate. If they are experiencing nausea and vomiting, it might be a good idea for them to take their pain medication, especially if it's an oral pain medication. If they take it with milk or if they eat something with it, that might help minimize that nausea and vomiting. And of course, if that does not work, then certainly we could administer an antiemetic. Of course, we would have to get a prescription for that. Another thing that we should have on hand is an opioid antagonist. I know we haven't talked about it yet. We're going to talk about it here soon. But let's have the opioid antagonist readily available just in case our patient is experiencing respiratory depression. That way we can give the opioid antagonist in order to combat the adverse reaction the patient is having from the opioid. We should also have oxygen on hand and other resuscitation equipment just in case we do need to resuscitate our patient. If our patient is going home from the hospital and they have an opioid prescription, we need to do some additional education. Make sure that they are understanding they should not use any other medications that could affect their central nervous system, especially central nervous system depressants such as alcohol. So we would educate them to avoid alcohol. And then, it's not the time for them to be going out and driving heavy equipment. That would require alertness, and we know the medications could cause sedation. And so talk to them about making sure they are avoiding activities that require alertness. Of course, this is not all the interventions that could go along with administering opioids, but it certainly gives you an idea of a plan of care for our patient if they do have acute pain and we need to give them medications. If your patient is already a drug user and they do have an addiction, we would have to implement additional interventions, the typical doses, the typical frequency of medications, or even the typical medications themselves. We might need to use stronger medications or above the recommended requirement just to get that patient's pain under control. It is going to be so much more difficult if the patient does have an addiction to opioids, it's going to be so hard for us to be able to manage their pain, especially if, they came in for a planned surgical treatment and now we're trying to manage post-op pain. It can be very difficult. So keep that in mind, because you're certainly going to take care of patients that are struggling with dependency. On this slide is a list of commonly used opioids that you will be administering as a nurse. So it's a good idea to become more familiar with these medications. Of course, some of these medications, they have multiple routes that we could administer. And so pay attention to that when you are administering. Make sure you have the correct route for administration. On your slides, you do have additional slides that give you a little bit more detail related to these common opioids. Please just read over those. Also, remember, you do have Nursing Central. I recommend that you look up each of these medications just to become even more familiar with these, because you certainly will be administering these opioids. But just remember, all the interventions that we talked about already, all of the adverse reactions that we talked about already, and all of those therapeutic reasons why we would give opioids, they would apply to all of these medications. And so, if you can just remember that each of these medications is an opioid, and if you can remember all of those important things to know about opioids in general, that's really going to help you as a nurse just to understand all of the interventions and all of those adverse effects that you would be looking for as a nurse when you need to be doing your assessments. I mentioned on the previous slide how some of these medications have multiple routes that we could administer, and this just gives you a side-by-side comparison. And I want to remind you, in past classes, we've talked about how IV medications, they are going to be right there in the bloodstream, and so they are going to very quickly cause a therapeutic reaction. And because they're not having to go through all of those cellular membranes as compared to the oral route, we see that we don't need to use as high of a dose for IV and even injectable forms such as subcutaneous or IM injections. And so it gives you that nice side-by-side comparison, showing you how many milligrams it would take if it was given orally as compared to whether or not it was given via injection. And then remember, if it is given via injection, we could go in sooner to reassess whether or not the medication is working much faster. So usually within a half an hour, we would expect to see a therapeutic response for those injectables, and then 30 minutes for the oral or PO medication route. Since we have been talking about opioids, we certainly need to talk about the opioid antagonists. We do have some different types of antagonists for opioids. And of course, you can see there's different indications for why we would give an opioid antagonist. If we have a patient that has overdosed on an opioid, we do have naloxone, otherwise known as Narcan, in order to treat the symptoms of the opioid overdose. Let's say our patient has respiratory depression, or they have even stopped breathing. Now we could administer the Narcan. And of course, now the opioid antagonist would bind to those receptor sites, the opioid receptor sites, in order to block the opioid from being able to cause the reaction. So essentially now we're going to reverse the overdose. We also have opioid antagonists to use if our patient has opioid-induced constipation. We have a different medication. It's called methyl naltrexone, otherwise known as Relistor. And so if your patient is experiencing significant constipation, it's interfering with their life and with, being able to eliminate their waste products. Now, certainly we do have another medication that we could use for that. If you go back to Nursing Central, to the psychoactive substances and that table that we were looking at previously related to narcotics, you will see what an overdose would look like. And of course, if your patient's experiencing an overdose, as the nurse, you need to recognize the patient is overdosing so we can quickly administer the opioid antagonist in order to reverse the symptoms of the overdose and save our patient's life. Again, just thinking about the receptors, you can see there on that picture, it shows you a little bit more detail of how the opioid antagonist would bind and block the opioid from causing more complications for your patients. Another location where we would see the opioid antagonist naloxone being used is, let's say we have a mom in labor and she is having a lot of pain in labor, and we administer an opioid to her, and then she gives birth. Well, the opioid could have crossed the placenta, and now we have a newborn that is born, and now the newborn's not breathing and it's in respiratory distress. Well, we could give naloxone to the newborn or the neonate in order to reverse the neonatal respiratory depression. It is a very common medication that we can use, just in case. Remember, when it comes to these opioid antagonists, they're only going to work for opioid overdose. If you have a patient, let's say they overdosed on a central nervous system stimulant, such as methamphetamines, naloxone is not going to work because it's very specific for the opioid receptors. And so just keep that in mind also. If your patient has overdosed on a different drug, it does not mean that the naloxone is going to work for all overdoses. Naloxone is that drug of choice to reverse the opioid overdose. This medication, it has been placed at law enforcement agencies, so all law enforcement will now carry naloxone. It's also being used by firefighters. They will have it. Paramedics will have it. Anytime an opioid prescription is being prescribed, it's very common that the provider will also write a prescription for naloxone. Naloxone doesn't necessarily need a prescription. It can be purchased over the counter. There are some places that are handing out free naloxone just because we do have this opioid epidemic in our country. And of course, if a patient's going to overdose, it doesn't mean they're going to be in the hospital overdosing. They're probably going to be out in the field somewhere or even at their home. And that is where they are overdosing. And so let's say law enforcement is responding because somebody has stopped breathing. What they will do is they will just go ahead and administer the naloxone because it's not going to cause any adverse effects if we administer it if the patient actually didn't use opioids. So they a lot of times will just administer it just in case because it's not going to cause any adverse side effects. And so if we're in doubt of whether or not the patient was using opioids and that's what caused them to stop breathing, we will just go ahead and administer the naloxone. Another opioid that we should talk about that is gaining more popularity, it's called tramadol, otherwise known as Ultram. It does work a little bit different in the body as compared to the previous opioids that we talked about. This one will bind to the U-opioid receptors, and it's going to inhibit the reuptake of serotonin and norepinephrine, and that means more serotonin and norepinephrine will be available for the body to be able to use, but essentially it's being used for pain, and it's given PO. It's an oral medication. I wanted to point this one out just because it does work on that serotonin, and I wanted you to be aware of if you have a patient that is on another medication that also increases serotonin, now they would have two medications that are increasing serotonin, it can increase the risk of serotonin syndrome. So pay attention to that. We don't want to cause a significant complication such as serotonin syndrome that could kill our patient. And we will talk more about serotonin syndrome in an upcoming class. Of course, there are some common adverse effects, some of the same that we've already talked about. And of course, there are some life-threatening symptoms, but here now we are seeing the seizures. And so pay attention to that also. Moving on, let's talk about some more central nervous system conditions and medications that will work directly on the central nervous system. Let's talk a little bit about migraine headaches. Migraine headaches can certainly be problemsome for our patients, certainly can interfere with their quality of life. It could lead to them missing school, it could lead to them missing work, it could lead to them, where they have to go home and they have to lay down in a darkened room and just deal with the pain, take their medications, and hope that their headache goes away. Typically, migraines, it's not just a headache. Of course, they do have a headache, and a lot of times it's very throbbing pain. Sometimes it's unilateral, meaning that it is only on one side, or it could spread across both hemispheres of the brain, where they are now experiencing bilateral pain in their head. It can also lead to additional symptoms. It could lead to nausea and vomiting. It could lead to pain in their neck. If their head's throbbing, what they're probably doing is they're probably tightening up their muscles, and now they're experiencing muscle tension. And a lot of times it ends up being like right around that same area because they're tensing up from that pain in their head. Can also affect their vision. It can lead to sensitivity to light and also to sound. So that's why going into a quiet room, a darkened room, can also be helpful. If they would try to just power through and continue to work or go to school, any activity like that could actually lead to an increase in pain and actually worsen the headache. So, pay attention to this. Certainly, we need to make sure our patients are getting that quality of life. When it comes to headaches, we need to make sure that if they are experiencing migraines, we need to know that it's actually a migraine. There's other types of headaches. There's tension headaches. People could just carry their stress on their shoulders, and it could just be the tension that the muscles are tightening and now it's wrapping around their head, and that's what's causing pain. There's other conditions that could lead to headaches. It could be viruses. It could be the flu. It could be a brain tumor. And so certainly we know that there's other reasons. So certainly they should seek health care. We want them to make sure that we're getting the accurate diagnosis and then the accurate treatment for them. A lot of times they can use over-the-counter pain relievers, and so we might not see patients who have other types of headaches. Typically, why they do seek treatment for the migraine is because it is interfering with their quality of life, like we've already mentioned. When it comes to treating a migraine headache, we really need to first understand the pathophysiology behind the migraine in order to understand how exactly the medications work to treat the headache. The textbook talks about how we don't know the exact, reason for why migraine headaches are happening. Of course, there are some theories. Some things that we do know that are happening is that with a migraine headache, there's inflammation that is happening, and we can see that on the picture. You might take note of that inflammation, and then we're also seeing dilation of the intracranial blood vessels. And so if we're seeing dilation, that's going to cause more blood to flow to the brain, especially in a specific area. And of course, that increased blood flow in that area which goes along with inflammation also, where the blood will start shunting and it will push more blood to locations of inflammation. And just that increased amount of blood to that area can lead to that pressure, can lead to pain. There are two compounds that are altered during the migraine headache. The calcitonin gene related peptide, or CGRP, we do know that these levels rise during a migraine, and that is what is promoting the vasodilation and that inflammatory response. We also know that serotonin is involved, otherwise known as 5-HT. And what we know about the serotonin 5-HT is that the levels will actually fall during a migraine. So keep that in mind when we start talking about these different types of medications used to treat migraine. Why exactly would a migraine happen? Well, the textbook talks about some triggers that could lead to migraines. It could be food, it could be aspartame, which is a chemical that is found in some foods. It could be that the person is fatigued or they are stressed, and that's leading to the migraine. It might be that they just didn't get enough sleep, and that is what is leading to the migraine. Maybe they're just not eating like they should. Maybe they missed a meal. Sometimes it's odors. Maybe there's some sort of an odor in the environment around them triggering the migraine. It could be light or light sensitivity that triggers it. It could be hormones changing. It could be medications. It could be the weather. There's so many different reasons why this could happen. When it comes to migraine, there's different types of migraines. There's migraines that don't have an aura, and there are migraines that do have an aura. If it comes along with an aura, and that would just be like this feeling that something is going to happen. So it's kind of like a premonition, or that feeling that they know this headache is going to come along. If they do have the migraine with an aura, usually they end up having visual disturbances about 30 minutes prior to actually getting the pain in their head. And of course, they could also have other symptoms like their speech being affected, their taste could be affected, or even their smell could be affected. It's not a secret that I'm struggling with migraines. You see that I implement interventions for myself in the classroom. I started experiencing migraines after being rear-ended in a car accident, suffering severe whiplash. And of course, my brain being rattled, something has happened where now I get these migraine headaches. I know for me, I do get the aura, and there have been times where, all of a sudden I just have this feeling that something is happening. And a lot of times my vision just starts to get blurry. And if I can take medication right at that time, then I can usually stop the headache from even happening. I know that lights are really bothering me. That's why I wear those tinted glasses. But, just thinking about those triggers, hopefully, not just having to use medications to treat the migraines, but if we can also use some other non-pharmacological interventions to prevent the migraines, certainly we will do that. I know that, just dimming the lights, that can certainly help. Fluorescent lights seem to really be bothersome to me. I have all LED lights at my house, so I don't tend to have as many migraines at home as compared to work. And I really think it's just the lights that are bothering me. But when it comes to treating the migraines with medications, we do have two different categories. We have some medications that will stop the migraine once it has already happened. And you can see there, even some over-the-counter medications could be used, such as aspirin or acetaminophen. We also can use the serotonin 5-HT agonist, otherwise known as triptans, to stop or abort the migraine headache. We also have ergot alkaloids that can be used. And then we also have preventative medications. And so not only use those non-pharmacological preventative measures, but also we have medications. So we could be using beta blockers. So think about it. We've already talked about beta blockers or antagonists. And here now we're seeing it being used, working on the central nervous system in order to prevent migraine headaches. Of course, it would have to be taken daily. And then we have tricyclic antidepressants that could also be used, and anti-epileptic agents. Both of those type of medications, we'll talk about those in later classes, but remember, they are working on the central nervous system. Where are the headaches happening in the body? The headaches are in the head. And so if we can give a medication that's going to cross the blood-brain barrier and get to the head, that would be a very good thing. And so, again, just thinking back to the pathophysiology that we talked about on the previous slide, you can see right here, some of the medications work directly on the happenings that are the process with the pathophysiology. And so, if we can give the calcitonin gene related peptide, or the ergot alkaloids, that is what's going to work on the RP, sorry about that. And that would help then to reduce the vasodilation and the inflammation in the brain in order to hopefully get rid of that headache. Same thing with the serotonin agonists that we will talk about. If our patient has a migraine headache, and we've already talked about how it can interfere with quality of life, we want to be able to stop this headache as soon as possible. And so certainly we would want to make sure our patients have a medication in order to take it maybe right when they're having that aura, or right when that pain starts in their head, because we want it to stop. So we do have the serotonin 5-HT agonist, otherwise known as triptans. This is going to be first-line treatment to stop the headache after it has already happened. This would be taken as needed only when having a migraine. If they're not having a headache, they would not be taking these medications. Notice these are triptans, and notice that all of these medication names end in triptan. One of the more common one is the sumatriptan, otherwise known as Imitrex. So you can see how exactly these are working right in the body, right where that pathophysiology of the problem is happening, and it's going to work selectively on those 5-HT serotonin receptors, and then cause the intracranial blood vessels to constrict in order to decrease the blood flow, decrease that inflammation in order to get that headache to go away. Of course, these medications, they are generally well tolerated, but certainly there are some serious adverse effects that we should think about. One of the big concerns we would have is it could cause a coronary vasospasm, where their coronary blood vessel would collapse on itself and vasospasm, and that could cut off blood flow to the brain. These medications, they are contraindicated if a patient has already had a brain bleed, if they've already had a stroke, if they have uncontrolled hypertension, if they have coronary artery disease. We wouldn't even want to go there and prescribe these medications to them. So make sure you pay attention to, these additional conditions that the patient might have, and just know that the triptans are not going to be safe to be used for these patients. Another one that, it's going to be concerning for the patient is 50% of the patients, they will start complaining where their arms feel really heavy, and now they start feeling pressure on their chest. Sometimes they say it feels like an elephant sitting on their chest. And if somebody's saying that to you, what might you think is happening to them? Well, you might think they're having a heart attack, but in reality, it's the medication that's causing this, and it's actually unrelated to ischemic heart disease. But, certainly if that's causing them a lot of pain and a lot of problems from the medication, that this side effect, we have other choices, other options. So certainly they should talk to their provider about that. Another thing that could possibly happen, like we've mentioned before, when we were talking about the tramadol, is here's another medication that could increase the risk of serotonin syndrome, especially if being used with other medications that will increase serotonin in the body, such as MAOIs, SSRIs, or SNRIs. Those are all antidepressants. We'll talk about those in a different class. When it comes to these triptans, they should not be used in pregnancy. So if you have a patient that has migraine headaches, and it doesn't mean they can't get pregnant, but maybe we need to get them a different medication to be using as a rescue medication if they would experience a migraine during pregnancy. Here's another example of a rescue medication if the patient is having a headache, a migraine headache, and they need the headache to stop. This is another as needed medication that they could take. So maybe the triptans, maybe they didn't work, they weren't effective for them. Here's another option. So the ergot alkaloids, an example of this would be the dihydroergotamine mesylate. The nice thing about this medication is it does come in a variety of different routes. And so they could take it intranasally. That's going to probably be the easiest way to administer it. But, if they're in the hospital and they have an IV and they have a massive headache, we do have other options such as injectable form in order to stop that migraine headache. You can see that this medication works differently. It's suppressing the release of the CGRP in order to stop the vasodilation, in order to stop the inflammation that's happening in the brain, in order to stop the headache. I mentioned that we have different options when it comes to treating the migraine headaches. Some things to remember, though, the patient should not have a prescription for the triptans and for the ergot agents, and they should not be taken together. They would be contraindicated. So it would be one or the other that they would take if they were experiencing a migraine headache. So don't use those in combination. The ergot agents are also contraindicated in patients with cardiovascular disease. We don't see a whole lot of side effects from these, typically well tolerated, but look at the one here. It could lead to nausea and vomiting, and yet the migraines can also lead to nausea and vomiting. And so now the migraine itself could cause that side effect, and the medication could cause that side effect. And so certainly pay attention to that being an adverse reaction. If they are experiencing that, the good news is we do have antiemetics that the provider could prescribe, and then they could take the antiemetic with their ergot medication. These medications, they could lead to physical dependence. It would be regular use. And the expectation would not be that the patient is experiencing migraine headaches every day. That certainly should not happen. But a lot of times, what they are saying, the prescribers are saying, only 2 doses per week. And so if they're experiencing more migraines, more than 2 a week, they can't take their medication more than twice a week. Why not? Well, they could experience drug rebound if they would take it too often. And now they could experience a headache from taking the medication too often. And certainly we don't want to cause that. Pregnancy, we need to think about that also. These medications are not to be used during pregnancy either, because it could lead to miscarriage or it could lead to preterm labor. And so again, avoid these during pregnancy. We mentioned that there are preventative medications that our patient could be prescribed in order to take these medications in order to hopefully not have any migraine headaches at all. And so beta blockers are actually the first line treatment for prophylactic use to prevent a migraine headache. And again, it would be taken daily. So I have an example. Propranolol is the typical medication that they are using. They aren't quite sure how it works for migraine headaches. They do believe that it stabilizes the vascular tone in the brain. It might also work by decreasing cardiac output. Therefore, that would then lead to decreased blood flow to the brain, which would decrease the likelihood of experiencing a migraine headache. There's additional examples of other preventative treatments in the textbook. Some of them are oral medications that, again, would be used daily. Sometimes it's a preventative medication that would be used, for instance, twice a week. Nurtec is one of those, and that could be used either to abort headaches, or it could also be used to prevent headaches if it's used on a regular basis. Interesting though, insurance typically only covers 8 tablets of Nurtec per month. And so pay attention to insurances also. They might not pay for all of these different medications that we have. We also have newer options. There's some injectables also, such as the Urenamab, and that's an injectable, again, preventative. It's an sub-Q injection. It's given monthly. That certainly can help to prevent migraine headaches. Again, newer medication, insurance might not pay for it. We also have additional treatments. They are using Botox for treatment also. When it comes to the Botox, it's way different than using it for cosmetics. There are a lot of different injection points for the Botox. They'll start here, they usually go out, then they go around the hairline, injecting Botox at all locations, and then they'll go down like both sides of the head, all the way down, and then usually out into the trap muscles. And the thought process is the Botox will help the muscles to start relaxing, because of course the thought process is the migraines are causing muscle tension, which is further exacerbating the headaches. And so if that can be helpful to relax those muscles, that can help prevent the headaches. Again, there's additional options out there. You have additional slides on yours talking about some of those antidepressants that we could also use to help prevent migraine headaches. Your textbook does not talk a whole lot about migraine headaches, but certainly, this could be a significant condition that your patient is dealing with, and we certainly want to be able to treat it to the best of our ability. So that's all I have. Just read over the additional slides that you have, and I will see you soon in class.